I want to thank, first of all, Tim and Dr. Stolberg and the Omni Group as a whole. Thanks very much for letting me be a part of this. It's been a great experience for me. It's been fun as well as a learning experience. My talk basically is going to be about everyday use of the ARC stem. I'm just a regular orthopedic surgeon in Oklahoma City. I'm primarily joint replacements, but I do some general orthopedics too. So I'm just wanting you guys. This slide, first two slides here, just basically showing types of things that can develop with standard stems in bad bone and the amount of bone loss that you typically see. But the one good thing is potentially there's some degree of restoration of bone density with certain implants. So that's in part what we're trying to accomplish with this stem. Basically the same thing here in a study earlier this year where they showed up to 40% loss of bone around the metastasis of the stem. So here's the type of choices that we have today and some of the questions that go along with that. My talk has more to do with just day-to-day use, but these are issues like thigh pain, loosening, subsidence, et cetera, that we are trying to determine, but still too early to really say too much about. As far as metal-on-metal articulations, I can just say I'm right now staying away from those, not to say I have a problem with them per se, but it does at least give you that option. Okay, this is the real question that I'm here to address, and that is, are neck stabilized stems appropriate for poor bone quality femurs? This is just a replay of what you've seen already, Dr. Doerr's classification and how we use that. Okay, this is my own personal experience to date, whether by optimism or ignorance or both. I started using this stem when it first came out in April of this year and have been using it as my standard total hip replacement since then. So I now have 63 patients, ages up to 91 years old. 27 of those, about a little over a third, are 70 or greater. Approximately a third of the overall group is B bone or beyond, or B or C bone, in other words. I use a standard table, direct to anterior approach. I'm not going to go into that specifically, but that's what I do. Maximum follow-up is 7 months, so obviously that you can't cull too many long-term results. You can't cull any long-term results from this, but at least we have some preliminary thoughts. All of these patients had an ARC stem and an apex cup with a non-lift liner. Revisions were excluded, and if they'd already had a total hip on the other side, many times I just did the same thing. Not had any dislocations. I have had one case of subsidence that I know of that I will show you here in a minute. I haven't been able to detect others, I'll put it that way. One of the sets of slides that you'll see here, though, are from another series of patients, and again, I'll show that here in a minute. This is basically type A bone, like you've heard discussed several times here this morning, or this afternoon, I guess. According to what Dr. Kepler has just said, that maybe this is oversized. You can see I did leave it a little proud. Frankly, I think this stem is going to be tight no matter what, but I don't know that you could really call that a neck stabilized stem at this point, but I think it's there to stay. And realistically, if you have good bone, I don't think it makes a whole lot of difference whether you have the stem in varus, valgus, neutral, or just however it happens to fit. This one obviously was going to go straight down the middle because it had no choice. Okay, so this is one of my patients, 50-year-old Caucasian female. Bone quality is not too great, even though she's pretty young. This was an intraoperative photo, and basically you can see where the calcar sits against the stem there and there. It's a little hard to see that, I guess. Here's the 2-week post-op film in my office. Here you can see she fits well against the calcars. What you probably can't see it very well, but there actually may be a little chip in the back part of the cortex here. Frankly, I don't get too excited about that. I don't think it really affects the stability much. it probably does disturb the hoop stresses a little, but maintaining the cow car, in my mind, is more important. So what I usually strive for in a patient like this is not so much to fit exactly along the cow car, but to make sure the cow car stays intact as much as possible, and potentially even to put it in a little valgus so that the distal flange hits against the anterior cortex here. Needless to say, by the way, we all made up these talks individually. We all have our own opinions. I mean, you're going to hear me say some things that somebody else might not necessarily agree with, but that's the advantage of being in this group. Okay, so this is the same patient 5 months later. She's doing fine. She's walking in my office without a cane or any problems, just a typical good total hip replacement. This is the patient that I had in my office that probably has settled a little bit. She's an 82-year-old female. These films were taken intraoperatively with a fluoroscope. If you look very closely, this cortex is intact here. The flange sits on top of that. It looks really pretty good. She goes pretty much down the middle of the canal down here. Here she is 2 weeks later, and the truth is I really didn't notice much difference. And I'm still not absolutely certain how much difference there is, but you get the hint anyway that this may have settled down into the canal just a little. Not so much evident on the lateral view. Here she is now 2 months later, and truth is this film was kind of a surprise for me because she came in doing fine and is walking without a cane. But when I made the film, obviously it looks anyway like she has settled there a little bit. I couldn't really see any lucency around the stem anywhere else, but she probably has subsided a little bit. So there's a 2-week film, in other words, and there's a 2-month film, and it looks like she probably has settled a few millimeters. But if you look at the rotation of the films, it's still, I think it's probably subsided some. I really don't know that I can say positively. If you look at the neck on the lateral side here, it's hard to say that she's really changed that much. So maybe that's rotation. It probably has settled. I'm not trying to say it hasn't, but I'm just not sure how much, put it that way. This is a patient that was not my patient, whose films were sent to me for this talk. And the truth is, this particular film is the first time I've seen it. But what you can see is, again, the cone is right up at the top of the cortex here. This is a really osteoporotic patient. It's got a very big canal. It's a little, even on these films, it's a little hard to see some of that. But it becomes more evident when you see the next films, I think. Here we go. And basically what you can see is, first of all, it's a very wide canal down here, but this stem has subsided a fairly significant amount, probably a centimeter or so is what I would say. And again, you can see how osteoporotic, this is truly C-bone without a doubt. Okay. So anyway, I've been told that this particular patient was not revised, was watched, put on crutches temporarily, and over a matter of a couple of months became pain-free. But obviously must have shortened just a little. Okay, well, as far as what I do personally to try to keep from having the stem subside is a few things, and I want to go over that if I could. First of all, if you watched closely on that video, Dr. Vaughn's, you noticed how he several times mentioned that he likes to put his awl right on the cow car and, quote, work the cow car. And I've heard that many times in talks about short stems. And it does make sense that you want to follow the shape of the cow car. But personally, and I think if you watch Dr. Kepler's pictures, he pretty much does the same thing that I'm talking about here, which is I really like to start near the middle and maybe even towards the back when I'm putting in the starter awl and the broaches, and then work around the curve. And as I said, if it turns out to be in a little bit of valgus, so much the better as far as I'm concerned. But as you put this all in and enlarge it from the next size to the next size, what's going to tend to happen is if you're right on the calcar already, it's going to tend to push it out and crack it. And it's possible that the same thing can happen posteriorly along the lateral cortex, but as I said earlier, frankly, I don't think that's too big a deal. This is sort of the ideal circumstance, but bottom line is to try to keep them from settling, you do want to try to fit the cortexes there as best you can. This would be posterior here, this is anterior. Again, sometimes this bone is just really almost paper thin, and it's almost unavoidable that it's going to split just a little bit. But I'd much rather personally see it split right here than have it split open here. Just to go along with some few things to do to try to keep the splits down to a minimum, or to keep the subsidence down. This, as you've heard, this has a T-back on it. It's porous coated down to here, and then it has an extension down to here. As you put the stem in or the trowel, again, you don't want to start on the very medial cortex and try to push it down, because then this is going to engage here too and tend to push things this way. So I'd like to make sure that I start way posterior and then match the curve all the way down. Okay, so should neck stabilized implants be used in poor quality bone? As far as I'm concerned, yes. I think they work very well in most patients. There are some type C bones that are particularly bad, as we all know, and maybe there's not a good implant for those in general, but at least for now, I don't think the question is fully answered. Just be a little careful. They can be used in situations where surface replacement is contraindicated due to osteoporosis or concerns about metal on metal. It's still a little early to assess for effects on thigh pain, bone remodeling, and stress shielding. Thank you.